I was in the middle of a busy day in my office as an oral surgeon. My nurse comes in and says, "Dr. Grellner, you've got a call. It's from the mother of a patient that you just operated on an hour ago. She got sick when she got home and passed out over the toilet, hitting her jaw." Great. What am I going to say? Hello, Mrs. Smith? "Dr. Grellner, Dana got sick and she passed out and hit her jaw. What do I do?" "Well, Mrs. Smith, I'd suggest you bring her in. Let's get a look and see if there's a problem." So she brought her in. Fortunately, there wasn't a broken jaw. But this was the moment that I realized that using a long-acting narcotic, doing IV general anesthesia, was a problem. I realized that it had been a problem going up to this, but this was the clinching moment. So I had to start looking for an alternative. That alternative was an ultra-short-acting narcotic called remifentanil. Traditionally, oral surgeons, even to this day, use a longer-acting narcotic called fentanyl that wears off in 60 minutes. So as you're giving the medication, you're guessing approximately how much narcotic to give in the beginning of the case. Whatever you give, that's what you have for an hour. Now, if the case lasts 30 minutes, you've got 30 minutes of narcotics still active. Patient nauseated, disoriented. Do a search on YouTube for wisdom teeth. Look at the videos that come up. They're of teenagers that are taking selfies of themselves, showing how messed up they are from their anesthesia. Well, if you're a parent, if you're a smart parent, you realize that that child is still suffering the effects of that anesthesia well after the time that the surgery finished. When I was at CNN in Atlanta, I pointed out to Dr. Oz that there's a video on YouTube of a teenager going through the office, leaving the oral surgeon's office. "Mama, the fish are drowning!" Is that the way you want your child to go home? Not me. I found the narcotic remifentanil by doing a reserve session at a local Air Force base because I was a reservist. It happened that day, instead of doing any major surgery, we were doing wisdom teeth. I said, well, great. Maybe they might have some remifentanil that we can see how it works. The anesthesiologist, when I asked him, he said, "You want to try it?" "Huh, are you kidding? This is like a kid in a candy store." "Yes, let's try it. Let's see how it works." So we tried it. He, of course, knew how it works and how to administer it. He administered the proper amount of the medication. Patient fell asleep. He said, "Go ahead, get started." Took out a tooth, no local. He's asleep, doesn't move, wakes up within a short period of time. At least one tooth is out. And incredibly, I had done this surgery without any local and with nothing else. Now, the way to actually administer this drug is you have to give it as a continuous infusion with a pump. So you're getting a continuous drip, 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 drip through your case. You can increase it, you can decrease it as you need, which is the key because this medication wears off in about 6 to 8 minutes. A bit different than 60 minutes. So for the first time, I'm able to actually decrease the dose of this narcotic during the procedure and see the difference within minutes. Because what I realized is that there are patients that have very, very different sensitivities to narcotics. Take a patient who's never had alcohol. You know, there's cultures where they don't. They're extremely sensitive to medications, especially narcotics. So now I had a way to be able to eliminate nausea and vomiting, eliminate the risk of a narcotic that maybe I've given too much in the beginning of the case. If you do have to do that, the longer-acting narcotic, you have to reverse it, and then your anesthetic is done. With Remi, you turn down the dose, you customize it to that patient, you do what you got to do, and they wake up clear, continuing a conversation with you that you had perhaps before they went to sleep, talking about the Cubs and their baseball game. No nausea, no recovery room. Got rid of my recovery room 18 years ago. And the thing, I mentioned no nausea, that's a thing I don't like. I hate that, thing. I run from that. So this was a blessing. Okay, so why go to sleep for a surgery? As a 20-year-old, I had my first Yeah, I only took one wisdom tooth out of the 4 in my brilliance as a college student. It was the one that was bothering me. I had one wisdom tooth removed with local. Didn't know how difficult it might turn out to be, but I was tough. Had that wisdom tooth removed under local, it was the worst experience of my life. What I realized is going to sleep, you don't experience the procedure, but even better, you don't remember it for 4 or 5 decades. You know, there are other ways to be able to be sedated for surgery. You can do nitrous oxide. Well, that's great for cleanings, but you're still awake. There are dentists that do dental sedation, but that's taking a sleeping pill. Guess how much control you have over that sleeping pill once it's swallowed? What if that one pill's not enough and the patient needs another? Well, take another. Well, now they're asleep and they won't wake up for an hour. No. I have control now that is the best control I've ever had and allows me to be able to deal with a patient who potentially has sleep apnea that I don't realize. If that patient has any issues with their airway, we just turn down the narcotic or turn it off. And then within minutes, they're awake, you can start again, finish the procedure, you're done. So, the choice, do it awake, a difficult procedure? No. Do a deep, long-acting narcotic when the surgery's only going to last 30 minutes? No. What I used for my kids, both of them, quick recover, IV anesthesia. Yeah.